Hello, good afternoon, everyone. Thank you for joining us to our nutrition rounds for today. On behalf of Dr. Daron Kahana, the president of the NBPNS, I'd like to welcome you today. We have a magnificent speaker, Dr. Ken Fujioka, today, presenting to us a very interesting case. This is an opportunity for you to earn MOC credit. Two credit points can be claimed by listing your attendance and participation in nutrition rounds. Please feel free to use the chat function for any questions you'd like to post. And also, I think it's a very relaxed, informal environment. So also feel free to turn on your video and participate via audio visual. I think it's always better to communicate by audiovisual rather than chatting. Without further ado, Dr. Ken Fujioka, the director of the Nutrition and Metabolic Research Center, Scripps Clinic, is here to present to us a very interesting case. Dr. Fujioka?
Thank you, appreciate it. I think the first thing I got to do is try and share screen. So I'm going to go hit that share screen button. Okay, can you see? Oh, I just realized you may have to disable all the pictures so you can see the full screen. I can't seem to move over to the side, but anyway, this is a very typical case that I see that is, to me, a nutritional problem that is not always the best taken care of. But actually, I think this group is the one that needs to start weighing in on the issues you're going to see that I'm going to try and bring up. So Patricia is a 60-year-old female wedding coordinator who comes to you because you're the nutrition expert. And she's about 10 years out from her gastric bypass. Now, she initially weighed 280 pounds at a height of 5'4". She lost all the way down to 200 pounds. She's regained about 15 pounds. And she used to see the surgeon pretty regularly for 5-6 years, but she's not seen really anybody for the last 5 years other than her primary care. And she was an early type 2 diabetic. And obviously these things have improved immensely with the surgery. And if there is one group that's been studied with bariatric surgery more than the other, it's this group, the diabetics, because they just get so much benefit. Anyway, she follows a group on Facebook that is targeted towards individuals who have had bariatric surgery. And the group often talks about the need to get checked regularly for nutritional problems. And she brought this up to her primary care doc, and he was honest to say, I really don't know what to check, but I know I got to look at a CBC and a chem panel, and oh yeah, B12 and folate, they got to be off or something. So he checks them, which they're all normal. And the other thing that she's a little concerned about is that she was hoping to get well under 200 pounds because she reads all this phenomenal weight loss on the internet about people who have bariatric surgery. So she feels like a loser. And, or no, she feels like she didn't lose. Anyway, her A1C has always been under 5.7. So her blood sugars are great. Her lipids are perfect. She doesn't have hypertension anymore. She did have a stone about 4 years ago, and she called the surgeon. He said, "Oh, you just need to drink more fluid. You're just dehydrated." So the first thing that you probably need to ask in this case is, what nutritional supplements do you take? She says, "Well, I have a couple of these vitamin chews, multivitamins, sublingual B12. I got to have my LipoSlim, that works really good, vitamin C," and she's on no prescribed medications. So just first off, to my panelists, is there any other nutritional supplements she might want to be taking?
Well, her chewable multivites, are they bariatric multivites or regular multivites?
That's exactly what I was going to ask.
She says she is not sure. She just goes to the store, the health store, and just gets whatever chewable multivitamins they have. She does not get them from a bariatric source, but she was heard on the internet that if she takes 2 of them, she'll be fine.
Not a good plan.
Right.
Okay.
And I assume that iron and vitamin D are not a part of this regimen.
Okay, correct. There is no iron. And that's a big one. Fortunately, she's not menstruating, but yeah, that's a huge one in this population. I'm sure you know the numbers. It's something like 80 to 90% of these women will become iron deficient if they're menstruating. But okay, so yeah, no iron, no vitamin D. What else? One more.
Well, trace elements, zinc, copper.
Okay, zinc, copper, that theoretically should be in the chews, but we don't know. We just don't, we'd have to have her bring in the bottle. One
All the
other one?
regular multivitamins are low in the B vitamin group. Okay, so B1, B2. So those can be issues.
Okay, and some, some people will actually give these patients a B complex. And again, it's tough because there's no data either way on this one that I'm aware of. One more thing that she's missing that we really want women over the age of 50 to be taking.
Calcium.
Yes, she needs calcium.
I thought she was taking the calcium. No?
No, it's not.
Oh,
not
sorry, missed that.
Okay. Oh my gosh, you guys, what kind of panelists do we have? Oh my God. All right. So what do you do? So what, and I'm going to tell you, there's no right answer right now, but what nutritional parameters are you folks going to check in this patient? Think about it, because we're going to go through them one by one. And this is just because, as you know, really my main interest is obesity, but is she underperforming in her weight loss? Is this good weight loss? Is this bad weight loss? Is she right on track? Panels, anyone want to weigh in? I'm putting you guys on the spot.
Just to clarify on her weight loss, she lost and stabilized. Isn't that what you said in the history?
Correct. Yes, she's basically 215, and she started off at 280.
Okay, so she lost
65 pounds.
Yeah, but she lost 80 and then went back up, which is a little bit, but that's typical. That's very characteristic.
Right. This is what they all do. That's exactly right. They're
How tall is she?
She is 5'4".
Okay. Yeah, I think we would generally like to see more weight loss.
Okay.
And did we specify this was this a Roux-en-Y or was it a sleeve? Do we know?
This was a gastric bypass. Yes.
So Roux-en-Y.
Okay.
So just so you folks know what would be the expected weight loss for a diabetic. And for whatever reason, diabetics struggle a bit more with weight loss. We don't know why. But she lost about 23%, and most patients will lose between 20 and 25% at the most after this surgery. So she's pretty much right on target. And it's not that she's not trying. As you know, the set point will really fight to maintain a certain weight, typically the highest you've ever been to, but because of the changes, she is pretty much right on track. So it's tough for her because she's hearing all these stories about this phenomenal weight loss, but the fact is these are stories on the internet. So you have to kind of get these patients to realize. All right, so these are the labs that are recommended. My all apologies to any dietitians who are on this call. And I only say that because you're going to see this is a group of recommendations by, there was no physicians in this group, no, just dietitians. Doesn't mean these are bad ones, but these are going to cover everything. But CBC, CMP, lipids, A1C, vitamin D, PTH, iron, ferritin, B1. You're looking for B12 when you're looking methylmalonic, folate, and then on down to zinc, copper, which was mentioned earlier. And so this is the guidelines. They're from 2016 and they're published. And if you go to any bariatric weight loss center, they're supposed to be getting these. Unfortunately, most of them don't, but this is what they've been told to get on this point. But I want to go point by point. I'm just curious because I need help now from the panelists. How do you see these things as something that should be routinely done? And I'm just going to hit these one by one. So let's start off with the CBC. What does this panelist think? Yeah, that's an easy one. That to me, and it's inexpensive. I'm fine with that. And in this case, it was already done. It was normal. How about a CMP, chemistry metabolic panel?
For sure.
Absolutely.
Yeah, it's easy. Yeah. Lipids.
More interested in the triglycerides for our purposes, really. But yes, of course.
But the lipid panel, the panel gets you that. So yeah.
That's right. That's right. By the way, does the CMP have a MAG and FOS also?
Usually not.
Yeah, I
Not-
usually
not
add
at my
that.
institution. Yeah. When I was training, they used to have an egg on there, believe it or not, but that was 30
Yeah.
years ago.
I generally have to order that separate myself, but I always like to get it.
Yeah, me too.
A1C.
Yep. Specifically with a history of diabetes in the past.
Okay. it can't
Definitely.
be bad. Vitamin D.
Yes.
Okay.
I'm sorry, I disagree with the current genre of saying that nobody needs vitamin D. You're discouraged unless you've proven with bone disease, because this group definitely needs it.
I'm with you on that. Vitamin D is crucial, and I think our guidelines are way off. I like to see those levels 50s to the 70s generally. So I think more people are deficient than we're recognizing.
Okay. PTH.
Periodically, I don't know how often yet, but I think that the final answer is not out yet, because we're seeing increasing bone disease and we don't understand all of the pathophysiology. And if you've got a high PTH, you'd want to do something about it.
Can I just interrupt? Somebody's got their microphone open and kind of noisy background, so they could silence. That's great.
Okay. Iron studies.
Yeah.
Okay. Vitamin B1.
Well, I don't know if you really need this. She's taking a vitamin every day. I don't know.
Yeah.
Not sure.
And she has no symptoms. She's not ataxic. She's not confabulated.
Yeah, I think you need these right after the B1, right after surgery. I don't think you need it long-term after, unless the patient has symptoms.
Our patient is 10 years out. All right.
Yeah, I don't think you need a B1 in an asymptomatic patient 10 years out.
Okay. MMA 1, methylmalonic acid.
Yeah, I would check this like maybe once a year or something in the patient like this. I mean,
How about in this patient?
I'd like a homocysteine also.
Okay. Interesting. Folate,
Yes,
vitamin A.
yes.
yes.
Really? Okay. Vitamin E.
I never measured that. I unless it, in a woman that not menstruating, not possible that they're going to be pregnant. I don't think that you need to measure this for just a routine bariatric.
Okay.
I generally don't either.
All right. K.
Same thing here, unless the patient's got symptoms of some sort of, bleeding diathesis or something. I don't know that I would do it.
Okay.
I generally do a protein though. BTIR.
Sure. Yeah, that's easy.
Zinc and copper.
10 years out, I think you should check this. I don't know if you can check it that often, but there are a lot of cases of zinc and copper deficiencies with the gastric bypass patients.
Okay. So this is just my own personal thoughts. Fortunately, this patient, a lot of this was already checked, and some I definitely would check. Some were already normal. Unless they have symptoms, I usually try not to get it. And now I'm talking as somebody who sits occasionally on these, our cost-effective panels, I like to call them. But, do we really need to get all of this? And this is a tough one. And there is no right or wrong. But let's show you what found out. So vitamin D is 31. PTH is elevated at 120. Calcium's 9. The rest of the labs are normal. What's your diagnosis? What's going on? This is classic vitamin D, true vitamin D
It may be
deficiency.
Yeah,
calcium.
it's secondary hyperparathyroidism.
Exactly. That's
Yeah.
what this
Yes.
is. And,
Yes.
and so that's why, in my opinion, you always want to get a PTH with your vitamin D, because the vitamin D by itself, as you guys probably were alluding to earlier, sometimes you need them higher. And
Yeah.
so a PTH is really, in my opinion, and again, technically I'm an endocrinologist, so I'm going to think, well, then what is the effect? And as you know, here's a woman who, and I could have put in even more stuff, but she had a kidney stone. PTH is elevated, okay? PTH is stealing calcium from the bones because there's not enough calcium in the blood. Her calcium looks normal, so we think everything's fine. But the fact is that she's calcium deficient because she's not taking calcium, and she's probably not taking enough vitamin D.
Right.
And so this, and again, I see this all day long, so it's easy for me to talk this way. And then I'm going to throw some real curveballs at you in the next couple of slides. How would you treat this?
Correct the
Calcium
vitamin
and
D.
more vitamin D.
Okay, how would you do it? So you can tell her to go over the counter. You can give her D2, D3. What are you going to do?
I don't think it makes a lot of difference whether you give it D2 or D3. I usually choose based on what the patient is willing to do or can afford. So
I
for
would
patients,
recommend
I give D2 because the insurance will pay for it, and more patients who have greater flexibility, I'll give D3 because they can buy it over the counter, and so that's convenient.
Okay.
I prefer higher dose D3 daily as opposed to the ergo
There
calcium
you
for
go.
all.
You got to get.
I usually tend to do 125 micrograms at least daily.
Yeah, I do the same, but I found that we have a lot of patients on Medicaid. And when it comes to prescribing it where they have to pay for it, or prescribing it where the insurance will pay for it, I get better success them taking it with the D2 where the insurance will pay for it. But I mean, I don't think there's a major reason to choose one or the other. I like D3 a lot, and most of my patients are on it, but the Medicaid patients really need to save on their budgets, and I'll have them take D2.
And it's also nice to have it as a prescription. They may be more compliant, with the prescription form.
Yeah. So just so you know, when you look at over the counter D2, it's literally.
Sorry.
It's an extremely, you're talking 2,000, 4,000 units. The D2 that's prescription is going to be 50,000 units. And unfortunately, older women are going to end up on this probably 4, 5, 6 times a week. And yes, it is oftentimes not covered, which drives me nuts because it should be, because it's a drug, but it isn't. So then you can go to D3. And again, this is more potent than D2. A lot of endocrinologists like to use this. There is a little bit more safety in D2 in that it's not quite as potent. And then you need to give calcium, and you need to give them calcium citrate because you bypass the stomach and the calcium is not acidified. So you got to give it in a acidified form. So this is what you need to give. And when I say a lot, I mean a lot. So I always just torture the fellows on this because they're supposed to know this, but it's really, when they give the recommendation for calcium, it's actually in the elemental form.
Yes.
So it's not in the combined form. So again, these are much bigger doses. So I'll tell them, yeah, 2,000 plus. All right. Now you really
get the pharmacies and hospitals just please do their order sets in the elemental form.
Yeah, no, it's a problem. So here's what's going to be where you got to really think this through. Try not to go to your gut, but think with your brain. So we put her on ergocalciferol, and she's getting 50,000 units 3 times a day. PTH is now down to normal. It's below 88. So we're clearly doing well. Calcium's 9.1, vitamin D is 101. And you're getting these nasty calls from the primary care saying, you've just made him toxic. Do you call me a loser? Is Fujioka teaching you wrong? Think about it. Is this true vitamin D toxicity or not?
Well, I say you only have vitamin D toxicity when you have both elevated vitamin D and elevated calcium.
Yes.
The calcium has to be up for it to be toxicity.
Exactly. So this is not uncommon. And sometimes I have to call the primary and say, hey, look, this patient has secondary hyperparathyroidism and we got to push. And it's tough for whatever reason, because you're trying to get a patient to take something, and I get the hardest cases because I'm the only guy who does this in town. It seems like nobody wants to do this. So I may have them on 50,000 units every day. But yeah, if I get a vitamin D level of 100, so what? As long as the calcium is normal and I'm not stealing any more calcium from the bone. Okay. And that's it. That was my case. So
That was
whatever you guys
excellent. Excellent, Ken. Thank you.
This is where I think this group, we're physician nutritionists. And to me, this list, we need to go through as a group and we need to make our own recommendations and we need to publish it in the ASN journal. And I think that will be, for me, one day when, I don't know how Dr. Rothkopf talked me into being president, but I will push that.
You were such a natural. You're just a natural.
Oh, so anyway, I would love to see us go through this again. Because quite honestly, I don't think to me, checking a lipids, that should be in the primary care's hand. Yeah, sure, CBC, CMP, those can get affected by nutrition, but some of these other things are really tough to figure out. And again, like B1, unless they have symptoms, I'm not going to check it. That's usually only a problem right after surgery, not years later. It's just extremely rare. I've seen it once in 30 years later on. Yes, Ruba, you got a question?
So I was wondering about urinary calcium to keep an eye on bone health.
Okay, you can do that. And I've measured it on these patients. And you know what? When you check their urinary calcium, it's like 0. There's like no calcium in there. So it is another way to let you know that they're clearly calcium starved because they're not dumping any calcium in the urine. It just, the first time, again, that I was teaching this to a fellow, and they did have an interest in nutrition, and they go, oh my God, there's no calcium in the urine. There's nothing. And, and they start to realize, well, yeah, you're not taking it, you're going to steal it. Oh, we got a whole bunch of chats there. Sorry, guys. Let me look at my chats. Come on, show chats, previews. Come on. Oh,
so
there we go.
Great presentation, Ken, and thank you everyone for participating. Sorry I was a little late, and I was listening. I wasn't able to participate, but I was listening, and I did want to ask a couple of questions, if I may, Ken. So, one of my common practices as a clinician is to at least very briefly go through a dietary history and ask the patient, what do you normally eat for breakfast? What do you normally eat for lunch? What do you normally eat for dinner? Just to get a sense of what their eating pattern is, to see if they're getting exposed to any, for example, dietary vitamin D, and also about their lifestyle, if they're getting exposed to the sun. There's obviously seasonality to vitamin D level. I'm not sure if the vitamin D that was checked for your patient was checked in the summer or in the winter. She lives in San Diego, so it's kind of summer all the time, right?
That's right.
But still, actually, in the northern hemisphere, you still have the sun angulating in the winter, so it's a bit of a misnomer to think that none of us are vitamin D deficient, because we still see vitamin D deficiency even in Southern California, and quite a lot of it. And I tend to see more of it in obese patients in general, which is always a little curious. Do you know, are you familiar with any data on vitamin D level in obesity? And is it indeed in general lower than the general population, or is this just my own kind of skewed clinical data?
No, that's a correct observation. As you get heavier and you have more fat mass, for whatever reason, we see progressively lower vitamin D levels.
And then they're not as prone to osteoporosis or osteopenia because of their body weight stimulating bone growth. So is the vitamin D deficiency in obese patients clinically significant? Do they develop bone disease due to their vitamin D deficiency?
So it's interesting because they can. It's typically seen in incredibly inactive elderlies, is what we see, because they're not getting enough weight bearing on their joints. We looked at things like step counts, stuff like that. And again, this if really low activity, they're going to be at risk because just from what you said, they're not getting the increased weight driving bone growth. They just don't get it. So it can happen, but in general, they usually have good bones, particularly younger patients, but the older ones, not necessarily so.
Yeah.
Let me just add, because I just reviewed this for the Pediatric Endocrine Society and presented because we've developed an interest in adolescent bone health for those patients who are undergoing bariatric procedures in the pediatric age group. And there's even less data on the pediatric than there are on the adult. So I started out with a review of the adult. And two interesting issues. One, obese patients do have increased bone mineral density, but they have increased fractures at the ankle, but decreased fractures at the hip. So the weight bearing seems to really improve the hip issues, but they don't have any benefit at the ankle. And obesity in adults is associated with, in adults and pediatrics, is associated with increased fractures just in the atypical areas compared to normal aging osteoporosis type fractures. So that's one issue. People are still trying to figure out exactly what the issues are, whether it's vitamin D, PTH, change in bone metabolism, all of those things which are not totally clear. Multiple different articles show different kinds of things, but there is definitely increased bone turnover in both children and adults after bariatric procedures. And it's worse after Roux-en-Y than it is after sleeve gastrectomy. So how much is due to vitamin D, I don't think anybody can answer yet. However, there are some bone health issues that need to be followed and addressed in this group of patients.
So, and do you think that the vitamin D deficiency in this patient, Ken, was purely dietary related? Was she malabsorbing fat and fat soluble vitamins, or was she avoiding foods like egg, yolk, mushrooms, fish, and dairy that contains natural vitamin D in it? Do you know? Do you have a sense of how her vitamin D deficiency came about?
This is combined. This is both calcium and vitamin D deficiency. But as you know, you can't really measure calcium levels because you'll steal it from the bone to keep it normal. So I guess you could say it's true vitamin D deficiency in that sense. But as Mike said, this is secondary hyperparathyroidism. So you're really looking at a couple of moving pieces here, that it's a little bit of both. It definitely is not diet. I can tell you that, in the sense that they will eat lots of protein. They're very good at that as a group because they're taught you got to get your protein in.
But there's no vitamin D in most protein. It's only fish that has some vitamin D, right? I mean, beef and chicken doesn't have vitamin D.
Yeah, they do yogurt too. They do dairy. Generally speaking, they can do that. Unless their dairy is ice cream, they can't eat ice cream after bypass because they get dumping.
I mean, was she not exposed to the sun? Does she not go out? Is she kind of an indoors person?
I don't know the answer to that one.
Yeah. I mean, I'm just wondering if the post-bariatric patients are malabsorbing fat to such a degree that they're going to develop vitamin D.
It's rare. There are, so, a Roux-en-Y is not all one operation, so the surgeon has a lot of latitude about how long he makes, the limb. And how much of a malabsorption is present, but it is technically it's considered a malabsorptive procedure. Some more than others, So I've had some patients who required so much vitamin D, like literally 50,000 units a day, to maintain their parathyroid status, and others that didn't need any extra, just what they were taking routinely.
Yeah, but John, we spent time measuring fat absorption and fat in the stool after bypass. There's none. So it's not the malabsorption that's doing this. It's usually inadequate intake of both calcium and vitamin D, because she did have a normal vitamin D level, but in order to correct this, you got to give pharmaceutical doses of vitamin D, and you have to make sure that they take calcium, which she wasn't.
Right.
Yeah, and go ahead, Melina and Ruba, you guys jump in.
Yeah, first of all, thank you so much, Ken. I think I'm one of the ones that was guilty of talking you into this, in addition to Mike being president. So sorry, but thank you. No, but I had put this in the comments, but I just would want your opinion on it, because especially being in LA, I see a lot of these patients after gastric bypass surgery looking to lose more weight. So can you just comment on what medications might be appropriate, if you would use Casimia, or if the GLP-1 agonists don't work as well in this patient population? Can you talk a little bit about that, please?
Sure. It's something we're studying right now. I'm trying not to do any more research, but I just couldn't help myself on the study because it's real clear that in the beginning, when patients get gastric bypass, their GLP-1 levels go sky high. They're very high. They're up to 5 times to 10 times normal. They get incredible satiety and they don't eat and they lose weight. But after about 4 years, they begin to slowly regain weight. And so we've been looking at GLP-1 levels or the satiety hormones, and they may in fact be low over time. For some reason, the brain figures it out or the gut doesn't respond like it used to. So one is, you could use phentermine with topiramate, no problem there. You could use a GLP-1 in this. If it's a sleeve, for sure, a GLP-1 is your go-to drug, because it turns a sleeve where you've removed ghrelin by taking out the greater curvature, and you add a GLP-1, it's just like a gastric bypass now. So those are what we do. And now we can get patients to, I mean, we're getting to ideal weight now, which is just amazing to me.
Okay, I'm getting a note from Dante that we need to wrap up because people are already lining up for our monthly NBPNS conference call. So I want to thank Dr. Fujioka very, very much. Excellent discussion, great presentation, very important topic. I don't think we can ever really get enough of vitamin D conversation, and definitely a happy hormone, and one that we all should, I think, supplement, especially in the winter months. And more data is really needed for us to understand its importance in immune-mediated conditions and maybe even psychiatric conditions. So thank you again, Ken, our incoming president. Very, very proud of you for stepping up and taking on this role. And I know, I want to congratulate you along with Melina and Mike and everyone else on the call on taking this on. So thank you. And thank you everyone for joining us. Again, just a reminder that you can submit your time at Nutrition Rounds for 2.0 MOC credits. This is not a CME approved session, but it is definitely acceptable for MOC. And we invite all of you to continue participating and send us any questions you may have. We really want to hear from our diplomats. So thank you again, everyone.